Some of the ways to evaluate a patient for stroke. Initially, you definitely want to fall back on your basics, the ABCs, airway, breathing, and circulation, checking the vital signs. And if it's not obvious at first, you want to definitely check for things like asking the patient, the family member, staff members at the facility where the patient is about weakness, numbness, tingling, any changes in their mental status, things along those lines. Once you've assessed and feel that there's a possibility for a stroke, one of the more common ways for a pre-hospital provider to assess a patient is the Cincinnati Stroke Scale. This has got 3 components to it. They involve facial droop, weakness, and problems with speech. The initial way to evaluate for facial droop is asking the patient to smile. If you see one side of the face moving less than the other, that would be a positive finding. You would also want to check for weakness by having the patient hold their arms up with their eyes closed, like this, and have them close their eyes for about 10 seconds. If there's a drop of one arm or if the patient's unable to raise it against gravity, that would also be a positive finding. And the last one is asking the patient to say, no, you can't teach an old dog new tricks. And if the patient has any problems saying those words, finding the words, or just isn't able to speak at all, that would be a positive finding as well.
As our EMS staff is very good at doing, I think monitoring the ABCs is very critical in a stroke patient, especially with large strokes that affect people's level of consciousness. Protecting the airway or aspiration in patients who aren't protecting the airway is a major complication that we often see either right after or in the days right after a stroke. So I think very close monitoring of an airway is very helpful for us. Stroke and myocardial infarction or coronary artery disease often coexist, and so we often also see patients who are having coexistent strokes and heart attacks. So monitoring of the heart rhythm, an EKG, pulse and blood pressure changes are very helpful for us. And that's also, especially high blood pressure, is something that's important for us in deciding if and when we can give IV thrombolytic therapy. So monitoring of the blood pressure is very important. Well, there are a number of different ways that a patient with a suspected stroke can be evaluated. I think some of the cardinal features that we ask patients to look for are also some things that we would ask our emergency medical staff to also look for. The major things we would be looking for would be weakness of half the body or of one limb, weakness of part of the face, sensory differences of one half or part of the body, visual changes such as losing part of vision or double vision, abnormalities in speech or language, or sudden change in level of consciousness. Those would be the cardinal features I would look at.
The 3 biggest sources of confusion that I think of when assessing a stroke patient are, number 1, their blood sugar, because it could be low. It could be a case of neuroglycopenia, which presents just like a stroke. Another is previous deficits from, prior deficits from strokes or traumatic brain injuries or other things like that that have caused deficits that always exist. Another big one is eye surgeries, which affect how their pupils react. Perhaps that right pupil's never reactive or is never reactive.
Well, this is certainly tricky. This is what we really have to do quickly in an emergency department, is try to triage people in terms of whether they are or aren't having a stroke. I would say in an older population, either hypo or hyperglycemia are conditions that can mimic a stroke, particularly in people who may have had a stroke previously. Sometimes their symptoms can come back more or less in the setting of very high or very low glucose. Similarly, people who have an infection or other metabolic process can sometimes have reemergence of some of their stroke symptoms. Other pathologies or other disease processes we would consider would be seizures. Not all seizures involve convulsive activity, so sometimes patients can be having seizures and present as if they're having a stroke, or can have weakness or language problems following a seizure, what's called postictal or Todd's paralysis. In a younger population, another condition that we would consider would be migraine, which can present in an acute fashion and can sometimes present with focal features affecting part of the body or language.
Some of the key physical findings seen with stroke patients are things along the lines of weakness, unable to move one side of their body, arm or leg. You might find a patient that has difficulty either speaking their words, such as slurred speech, problems finding the words. This can sometimes appear to be confusion or changes in their mental status that typically are found by the patient's family members or staff members where they're located. Other key findings found with stroke, other key physical findings found with stroke patients also include facial droops and discoordination, either with movements of their arms or legs, or problems with walking can sometimes be the first things that are recognized.